Bueno, quiero dar las bienvenidas a todos que aquí están para asistir y a los monitores que tenemos hoy día también, aparte de nuestro dignísimo palestrante. Hoy día tenemos al doctor Víctor Villegas para ser monitor, es profesor asociado y director del programa de residencia de la Universidad de Puerto Rico y es certificado pela American Board of Ophthalmology, reviewer the American Journal of Ophthalmology y the Ocular Oncology and Pathology Journal. Thank you very much, Dr. Victor, for being here. And we have also Dr. Daniel Moreno, que es profesor titular at UNAM, está en Ciudad de México, es jefe del Servicio de Retina del Hospital General de México, coordinador del Servicio de Oncología Ocular de este mismo hospital y médico en Spanish Hospital of México. So, bienvenidos los dos, muchas gracias por aceptar la invitación y ustedes tienen la palabra para presentar al doctor ARUN.
Gracias, doctora Pare. It is a pleasure for me to introduce Dr. Arun Singh, who is currently the director of the Department of Ophthalmology, Ophthalmic Oncology in the Cole Eye Institute at Cleveland Clinic, Ohio. He is a fellow of the Royal College of Ophthalmologists, London, United Kingdom, and the American Board of Ophthalmology. He has published more than 160 scientific articles in peer-reviewed journals and has edited a major textbook, Clinical Ophthalmic Oncology, published by Elsevier. He is the editor of the British Journal of Ophthalmology and Clinical Ophthalmic Oncology. It is my pleasure, and without further ado, Dr. Arun Singh.
Well, thank you very much for this very generous introduction and for asking me to contribute. I was looking at my program, and I was supposed to be in Peru this week, going to Machu Picchu before coming to the conference in Lima. So anyway, I'm not there, but my mind is there, okay? And through Zoom, we connect with each other. So I chose this topic of uveal melanoma aspects of mortality for many reasons. Number one is that we hear about different things of melanoma, TTT, plaque, radiation retinopathy, early diagnosis, nevus, melanoma, whatever, all kinds of things. But really, nobody talks about the death from melanoma. And that's a very important aspect as far as the patient is concerned. That's what he wants to know. That's what he's worried about. But we really don't have many lectures or talks on this topic. I've not heard them in a long, long time. So I thought I'll talk about this because I think if you focus on it, you'll learn many things. I am from a Cleveland clinic. I've been here for many years now, and we have a very robust program. We take care of many patients, and everything seems to be beautiful here in Cleveland. I have some conflicts, but they're not of any relevance to this lecture. So uveal melanoma, we all know the aim of treatment is to reduce, the main aim is to reduce the tumor-specific mortality. And this is important to understand the words, different words of mortality, and we'll discuss them as we go. And of course, if you can save some vision, that's great. But really in cancer business, we're talking about mortality more than anything else. And in the next 30 minutes or so, we're going to talk about what we understand about metastatic process, what determines the risk of metastasis, what's the effectiveness of metastatic therapy once they have metastatic tumor, and or is there anything we can do to not get there, to treat before we get the macro metastasis. So the terminologies are important, and we'll talk about them as we go forward. So this is what we're going to cover. This is our current understanding, and of course, it's evolving. So next year, perhaps there'll be something else that we know more about. Maybe exciting, may not be so, but still, it's a process, and we learn as we go. So before we go further, let's have a little structure to our discussion about the sizes and terminology. I think terminology is important. So we know from collaborative ocular melanoma study from the United States, North America mostly, they divided choroidal melanomas into 3 groups, small, medium, and large. Of course, there is AJCC classification as well, and you can use those classifications. As long as you classify your tumors in a certain way, I think it's okay for us to relate my study data with your outcomes. But if you do not classify the patients or do not say what stage they are, then all our study data is actually meaningless because nobody can check on it and nobody can reproduce it, and we really don't learn anything from it. And this is the classification system for the COMS. The reason I use COMS because it is the largest prospective study, has produced almost 40 papers over 30 years, and has a very high quality data. So whatever numbers you get from here are robust and reliable because this is a prospective, multi-center, at least, and some of them are randomized studies within this many studies. So this is a classification system, and we look at small melanoma, medium melanoma, and large melanoma. I have to say that COMS never defined a nevus, but anything that's less than small melanoma can be considered a nevus. But nothing stops a small melanoma being smaller than small. It's just a classification system. Of course, it was smaller than what it is today sometime when it started. So it's an evolution. Medium melanoma did not become medium one day. It was small before, and before that was even smaller. But this is, when we see them, this is the size, this is the name we give it. Now this is important, at least for my practice, how we approach our patients as to what treatments we offer them. So nevus definition is by default less than small melanoma, which is about 5 millimeter in base and basically flat. 1 millimeter means it's normal choroid and it's flat. Slight thickness, we can still call them nevi, but anything more than 1 and between 2.5 is actually small melanoma from the name of it. Not the behavior necessarily, but from the name. And if you look at the tumor-specific mortality, now this is biopsy-proven metastasis. And if you look at the patients, and there were more than several thousand patients overall in the COMS, the small melanoma metastasis rate at 5-year mortality, tumor-specific mortality, is only 1%. So if you have a 95-year-old patient with small choroidal melanoma, think very hard before you want to enucleate that eye, because their risk of dying from the tumor with treatment is only 1%. This is important. And in that elderly age group, the risk of dying from something else is actually higher. So they're going to die from heart disease, stroke, etc., and not necessarily from a small melanoma that you're after all the time. Medium-sized melanoma is 10% at 5 years. And large is, of course, about 25%. So there is a direct correlation between the size and the tumor-specific mortality. This is not overall mortality. This is tumor-specific mortality, biopsy-proven metastasis. Much lower than overall mortality. So that's overall survival. This is metastatic disease. Come back to an older study. Again, COMS reported 15 years ago now. And this is the composite of their patients. And they said overall, as the time goes on, the mortality keeps going up. At about 12, 13 years, it's about overall, all the patients put together, mortality rate is about 18-20%. So as the time goes on, you say, after 10 years, maybe it seems to flatten a bit, but it still goes up a little bit, up to, if you have other data, up to 15 years. So you're reaching about 18-20%, something like that over time. But this is 2006. Look at the study here from Fuchs. I don't understand German very well, but the number is very striking, 18.5. So really? And we all know Fuchs wasn't living a few years ago. This was 1882. So 1882 and 2006, that's many, many years. And that number seems to be about the same. So what does it tell you? There's a better source of information, and that's called a SEER database. Surveillance, epidemiology, end result program of the NCI. It samples about 30% of US population, and in that population, every cancer, every tumor, treatment, outcome is recorded. This is like American census for population. This is the American census for cancers. So every data in the United States for breast cancer, lung cancer, prostate, colon, any cancer you talk about comes from this database. The federal money, NIH money, NCI money, all comes from these numbers. Everything comes from this database. And uveal melanoma is also in this database, and you can get this information. You can search it. It's available to you. And if you take the database, and this is up to 2018, and it's showing 2003 because we're looking at 5-year survival. So cases diagnosed up to 2013 and then followed for 5 years. That's 2018. And you're looking at relative survival. Relative survival is survival of the patients compared to the normal population, adjusting for changing lifespan in America. In 1970s, patients were living up to a certain age, and now they live longer. So adjusting for all those demographic changes and comparing melanoma patient with normal population. And you find out that their survival from 1970s to 30-year period has not changed. This is the most clear information to say what we suspect clinically, that the survival of the patient with uveal melanoma has not improved. So if you say, oh, we have done great work in ocular oncology, we haven't changed patients' outcomes, this is the most important outcome. In fact, this is the only outcome that matters. You can save the eye, you can have radiation retinopathy, you can have an exotropic eye, neovascular glaucoma, all kinds of things after treatment. But if you do not improve the survival, I'm not sure you're doing them a good service. And first of all, we need to be aware that we actually have not made any difference. So this is the truth. And the question is why? Why is it not any better? Skin melanoma is better, breast cancer is better, lung cancer is better, colon cancer is better. But there are some tumors, for example, pancreatic tumor, one example, and uveal melanoma is another example, where the rate has not changed. And that's because we know that there's an early metastasis that happens in uveal melanoma. And the tumor can stay in the liver for many years before it manifests. Well, let's look at that further. I'm now taking you back to 1978, Zimmerman's landmark paper that talks about mortality after enucleation. It says 2 years after enucleation, the mortality goes up and then goes down, and by 15 years, it levels off. And he said, he's a pathologist, he said, this was due to enucleation. Enucleation was making the patient die. So there was a time in America where people would say, if you have melanoma, you need treatment for enucleation, but no, don't do enucleation, because if you do enucleation, you will die from it. The tumor will spread because of enucleation. Go 25 years forward, I published a paper in BJO 2004, and we said, now we have data from other treatments, let's plot them. This is CMS data for enucleation, similar graph, but this is with the plaque, very similar, and this is with the proton beam from Harvard, Massachusetts Eye and Ear Infirmary data. So you can see similar graphs, no matter how the patients are treated. So what is it telling? That this is not due to enucleation. It is due to the natural history of the tumor. This is how the tumor is manifesting in the eye and the liver, and has nothing to do with the treatment. All treatments will give you the similar graphs. And without going into too many of the mathematical calculations, we published another paper in 2001, which talks about the inferred growth pattern. In blue is the growth of the uveal melanoma. So at the time of uveal melanoma diagnosis, somewhere here, the metastasis at the time in the liver is very small. And if you follow over 2-3 years later, that becomes macrometastasis. So you say, well, let's follow the line backwards. You know, you have a curve now, and you're going to go backwards. When you take it to the earliest level possible, at that time, the eye tumor is actually very small. So uveal melanoma is already a systemic disease by the time the patient is coming to us. We understand that, but this is a mathematical model to explain that. So by the time patient comes to us, micrometastasis has already happened. So if you keep treating the eye, it's palliative treatment. And there is histopath data to show single cell metastasis in the liver, which is not detectable by any scans or liver function tests or x-rays that we do. This is not detectable, obviously. So then if you want to start to say, okay, now we know the mortality is not exciting, it has not improved, what can we do to reduce the mortality? Well, there are only two ways, two approaches in very broad terms. First is early diagnosis and treatment of primary tumor. And second is early diagnosis and treatment of the metastatic tumor. So let's explore these two. I'm coming back to CMS again. This is a prospective study. And if you look at the small choroidal melanoma, these are tumors that were not treated. They were just observed as time went on. And about 1/3 of them grew by about 3 years. So this is small melanoma, but only 30% are growing and 70% are not growing. So do we still call them melanomas? How can melanoma be not growing in 5 years? There's something wrong with this terminology here. That means most of the patients in this classification are actually nevi, 2/3, and 1/3 are true melanomas. So this is what this curve is telling me. So there's a problem with the terminology. We say, shall we call it small melanoma? Shall we call it suspicious nevus, atypical nevus, large nevus, dormant melanoma? You see all these kind of words in different talks. All of it is wrong. And because of this terminology, people give different opinions, different options, etc., etc. So essentially what you're left with is when you see a patient, you say, oh, one side can be a nevus, the other side is melanoma, and you're trying to make a clinical diagnosis. Somewhere in the middle is the patient, and trying to say, oh, I think it's more like a nevus, I think it's more like a melanoma, based on many things that you've heard about before. But you can't be sure it's 100% is nevus or 100% is melanoma, because we don't biopsy them. So therefore, it's best to say that we do not know for sure what it is, and why don't we just call them indeterminate lesions? This terminology is applied to other parts of the body too. For example, in lung area, they see something, they say this indeterminate lesion, we'll follow it. They have criteria, they have size, and they have guidelines for it. So we can apply the similar correlation for other parts of oncology and say, this is indeterminate lesion, it's not a nevus, it's larger than nevus, but perhaps it's behaving like a nevus, we'll follow it, see what happens. So coming back to this classification system, we change the name to indeterminate and say this could be indeterminate tumors, could be nevi, could be melanoma. It's a mix of many things. At least two, nevus or melanoma, and maybe other variants that we don't know yet. So that's the problem. So we don't even have a good definition of early tumor. So we have a problem treating early tumor. If you treat everything in small melanoma, 2/3 will be melanoma, nevi, and 1/3 will be melanomas, and you make many, many people blind. So we need better criteria for diagnosis. And let's talk a little bit more interesting. Early diagnosis and treatment of the metastatic tumor. Why early? Because I mentioned in the graph that metastasis happens when the tumor is relatively small. It's preferentially hepatic, 90%, and the metastasis is microscopic by the time we make the eye diagnosis. So it's not obvious at presentation, but it's there in every case. So let's look at the biological model here. So here's a melanocyte of the choroid that becomes into a nevus, and we think most of the melanomas arise from the nevus, and we say there are two kinds of melanomas, let's say a low-risk melanoma and a high-risk melanoma. But there's a micrometastasis happening in all melanomas, whether it's low risk or high risk, doesn't really matter. We also believe at present that there's no transformation from low risk to high risk. What's low risk will stay low risk, and that's high risk will stay high risk. So in high risk cases, micrometastasis becomes a macrometastasis. Whereas in low risk, it just stays as micrometastasis. there is many lines of testing and evidence that supports this approach of thinking. So what predicts that somebody gets from micro to macro? So we are starting to get into, okay, so micrometastasis is universal. Choroid is full of blood. It's not surprising tumors are circulating. Then what's transforming micro to macro metastasis? Well, number one, we know size. I mentioned to you already, larger the tumor, more likely that will happen. We also know from the location, we know iris tumors have a low risk, for example, ciliary body have a high risk, size for size, and choroid has in middle. So location has something to do with it. We also know from many years of pathology work that epithelial cell type and tumor infiltrating lymphocytes, presence of it, mitosis, extraocular extension, are all factors that give rise to bad prognosis, let's say. And more recently, we start to get into cytogenetics, which are much superior than the traditional clinical path prognostic markers. We know monosomy 3, this is critical, and duplication of 8q. And of course, this is the way how you look at monosomy 3. So when you say, what's monosomy 3? If you take a normal tumor, UVEAL melanoma sample, and you stain the chromosomes, let's say red is chromosome 3. So in a normal sample, you're going to see 2 red dots and 2 green. So that's 8 is green, and red is 3. Chromosome 3, different paint for different chromosomes. And if there is only one red, that means they lost the chromosome 3. That's monosomy 3. And this is, in green, is multiple copies of 8. There should only be 2. Every chromosome, every cell has 2 of each. So this is only 1, that's monosomy 3. And 8q is duplication of 8. So if you see this in the tumor cell, then that's bad news. And this is called FISH, fluorescent in situ hybridization. This is one of the older tests. Karyotyping was the first one, and then you moved on to FISH. You don't need enucleated you can do this on single cells. So here's a single cell with 2 dots. This is disomy of chromosome 3. This is disomy of chromosome 3. This is the monosomy of chromosome 3, because this probe is specific for chromosome 3. There's only one red dot. So you count about 200 cells, and you can then make a correlation as to number of cells positive, negative, and then come up with an answer. So this is the older way, let's say, but this gives you a visualization of what monosomy 3 is all about. And we do biopsies with needles nowadays, 25 gauge needles, iris tumors, ciliary body tumors, posterior tumors, and they are very safe, generally speaking. Small risk of hemorrhage, mostly the hemorrhage goes away. Small risk of retinal detachment. The retinal hole from the biopsy will heal very well. Things like endophthalmitis, tumor dissemination are very, very uncommon. But keep in mind that not all biopsies will give you an answer that you're looking for, and the technical failure can be anything 1%, 5% at the most. Shouldn't be more than that. I think once you get settled in this process, your technical failure goes down. So if you come back to monosomy 3, and this is a paper from almost 20 years ago, if you have monosomy 3 in the tumor, you die. And if you don't have monosomy 3, you live. So there's a clear demarcation of tumors. We know that for 20 years, more than 20 years now, that patients with the tumors, this is only the tumor sample, if they have monosomy 3, they will die. And if they don't have it, they'll survive. And this is good for survival. 300 months is you can see how many years that is. It's quite a bit, 20, 30 years. So it's a long kind of follow-up. And now we have better techniques, molecular techniques, and they're different names: CMA, MSA, SNP, MLPA, GEP, different names. But essentially trying to prognosticate the patient. They're all good. This is one way to show the data. This is the Kaplan markers of SNP patients, disomy and monosomy 3. If you have disomy, they live. If they're monosomy, they die. This is using MLPA. Again, if they're normal chromosome 3, they don't die. But if they lose, they do. Different technique of doing the same thing. Then you have gene expression, which of course is not a DNA-based test. It's an RNA-based test. And that divides class 1 to class 2, which roughly corresponds to monosomy and disomy. So it's not a perfect correlation, but it is a close correlation between class 1 and class 2. And in the US, we have two commercial tests. One is based on DNA, which is MLPA test, and one is based on RNA, which is GEP test. I would say that both are equally good. They give you information that you can use to counsel your patient. They have been certified, they're commercially available, and they have certain data. But when you look at the data from these studies, you send a sample to the company and say, hey, can you do me MLPA? They do the MLPA, and they say, oh yeah, you have a 90% chance of survival at 3 years. Well, that's very good if it's good prognosis. Sorry, if it's good prognosis is better. This is the bad prognosis, say 90%. So still have 10% chance of death at 3 years. That's what they're trying to say here. But then you send the other test, GEP test, while their numbers are very different. They say your chance of survival is only 60%. I mean, you're going to die. So look at the difference. They're not comparable. So you cannot say one test is equal to a different test. If you want to do some studies, if you want to enroll patients for treatments, you cannot use two different tests. You've got to have one test because each one gives one answer. So they're looking at different things and the data interpretation is different. The numbers are not comparable. I just want you to know that. Let's move on. And there are many reasons why there's a difference. Most important, I think, is that when you're looking for these test outcomes, you should be looking at metastasis-free survival. Patient has melanoma, he then gets metastasis. What's the time from the eye diagnosis until they got liver metastasis? So that is called metastasis-free survival. This is a critical interval that we need to know. The question is, how did you find metastasis? Did the patients have ultrasound? Did they have liver function tests? Did they just wait till they got jaundiced? Or you went to find out from the death registry that they were dead or alive? It matters, because if you find by ultrasound, you're going to find it before it's very big. So you're going to have an early diagnosis. So if you look at the patients, here's the eye treatment, here's the eye, here is the metastasis, and here's the death. And based upon how the metastasis was diagnosed, this interval from metastasis to death can vary from small error to large error. If you did with the ultrasound, all you're doing is you're catching the metastasis early. If you wait for no surveillance, the death is about the same time, if you think about it. So forget metastasis, you say eye and death. And you say, how was the test done? How was the metastasis found? So this interval itself from here to here is several months. This is called lead time bias. Patients living longer because you found the disease early. That's it. And this itself is many, many months. Leave that aside. So that's a statistical problem with the trials, how we normally measure these numbers. With new information coming on about the molecular pathogenesis of uveal melanoma, we say melanocyte becomes a nevus and is driven by mutation in this gene, GNAQ11. 90% of uveal melanoma have this. This is very unique. But this is also present in nevus. So that when you have this mutation, you can be nevus or melanoma. It's not fully become melanoma yet. And then from the nevus, there's a bifurcation. If you have these two mutations, SF3B1, E1, F1AX mutation, you get into a low-risk melanoma or non-metastatic melanoma. It's not non, it's a low metastasis melanoma. There is some metastasis that happens later on, maybe 10%. And metastatic melanoma, which is driven by BAP1 mutation. So melanocyte to nevus, I think this is important to understand. And there are other mutations too, so there are few. But this covers 90% of what's happening. And there are other genes that play a lesser important role. So I just show you the main ones. So the melanoma can go one way or the other based upon the mutation. So when you're prognosticating, you can look for these mutations and you can find out if you have this, you're going to get metastatic melanoma. If you don't have this, and if you have this, you're going to get a different kind of melanoma. And we also know that they don't transform. So today you have melanoma, and I did a little biopsy and observed and start to grow, then it becomes metastatic melanoma. No. This bifurcation is a very early event. It happens at the onset when the melanoma forms. And there are at least 2 studies, one from our group, one from Bill Harper's group, that shows that at genetic level, this is very early dichotomy. So that when the tumors are going for micrometastasis in the body, there's an immune process going on too. So we can catch some proteins in the blood, for example, that show correlation with monosomy and disomy 3. You can also find circulating microRNAs, circulating tumor cells, circulating DNA. All these are under current investigation to correlate with the metastasis. But all these are possible. You can find the tumor cells, you can find the tumor DNA. Depends on how sophisticated is your method or technique of isolating the blood and the cells from that. This is a summary, it's a little bit older paper, but you can read some of that there. So let's talk, we talked about the metastatic determinants so far. What drives the metastasis? The mutation, the size, the location, right? These are 3 main things. And the immune process. Sometimes it can just stay there. Not everyone with BAP1 mutation will die or develop metastasis. 80% may get, 90% may get, but not all 100%. And same thing with low melanoma. It's not 0, maybe it's 5% that they will get. So there is some other host mechanisms too that may be important, some small fraction of it. But let's look at what's happening to the therapy of metastatic tumor. The summary is not very good, poor outcomes. And I'll show you some data from our own center. These are 100 patients over many years that we collected and we published here recently. And we divided them by different treatments that they got for metastasis. No treatment, local treatment, immune therapy, chemotherapy. Of course, no treatment is not so good, so they only lived for a very short time. So this is called swimmer plots. Swimmer plot is a good plot if you're trying to show time event, progression of, so you see each patient, each line is 1 patient. So you can see all the patients here, not just a number. So what happened? Very visual. So you say, many patients with no treatment lived for only what? Few months and they died. Follow-up for metastasis, maybe a few months they died. All red lines. Patients with chemotherapy, which we know is not effective, also at the most what? 3-6 months and that's it. Years, so that's years, 3 years, 36 months. And with new immune therapy that is good for skin melanoma, no different. So ipilimumab and novolumab, and these are hundreds and thousands of dollars of treatment, no difference. Only difference would be in some patients that had local therapy like laser ablation, surgical resection, single isolated liver mets. But maybe it's a different kind of met compared to other patients, it's possible. And then we tried to correlate. So I made in the center the time of metastatic diagnosis, not the eye diagnosis, but metastasis. And now go backwards. This is what the eye thing was, how much they happen. There's no correlation, okay? It's not that they have to get it after this, live longer, etc., etc. So I want you to keep, when you study melanoma, metastasis in the center. You don't see this kind of graphs, okay? They don't exist because we don't plot them this way. We start with the eye and we reach to met and we don't know anything after that. So you really keep the met in the center and then plot it this way and that way. Then you understand what's happening. So we know metastasis at high mortality, they're not getting any better. And from the tests that we have, we can find out which patient is going to get the metastasis. So why do not we treat these patients with adjuvant therapy? Adjuvant therapy means therapy in addition to primary therapy. If they need a resection, do the resection. If they need TTT for small tumor, you can do that. If they need plaque, do that. Enucleation, whatever you think is the right, proper primary therapy, do them based upon size, location, vision, patient's access, preference, whatever. Okay, so you've done all that. But that's only half of the story, maybe less than half of the story. That's only local control. But here, it's a systemic disease. So you need to think about what else can I give this patient? Because I now know, out of 100 patients, if I sample every case with the test that I have, I can tell who's going to get met and who's not going to get met. So the one who's not going to get met is great. But the one who's going to get the met, what can I do to stop, in his case, conversion of micrometastasis to macrometastasis? That's the adjuvant therapy. And again, you have to go back to the cellular mechanisms, genes, etc., which most of us don't understand, and you don't have to know it all. You just find good partners in your departments or hospitals who deal with this kind of stuff and work with them. And they will give you the ideas which drugs are good or which are not good. So coming back to the same landscape model that I made, there are drugs that can work on different genes in this, and the list is changing constantly. Every few weeks, there'll be one drug, people get excited, and then they find out it doesn't work, then they move to the next drug, and they keep moving. Okay? But that was somewhere in this, it will be the answer if you understand the genetics or the basic pathogenesis of drugs. So basically, since the patients are healthy, they have micrometastasis, but they feel normal, they don't feel anything. So chemotherapy is not going to be the answer, because chemotherapy can be very toxic and they may die sometime from complications of chemotherapy. There are patients who have had those issues in the past, where people were highly aggressive looking for new drugs. And nowadays, most of the emphasis is changed to immune therapy, targeted therapy, drugs that affect the specific gene mutations. Those kind of approaches are going to be useful for adjuvant therapy because they are specific and they are well tolerated. So the quality of life of the patient is normal, and they continue to be normal and get this treatment. This is a recent search. There are many trials you can go, and all of them are listed in clinicaltrials.gov. So if you want to know which trial is available, you can go and search on this website. It's mandatory for all trials to be listed there. If the trial is not listed there, they cannot publish the results of the study. You understand? So every company, before they do the trial, they have to register, get the number, so that everybody can see which drug trials. It's not 100%, but you get good information as to which trials are going on and what's happening to them. So there are certain agents, you can see I listed them here, and they are early promise, but nothing that's proven to be effective as yet. But we will have, in the next few years, there'll be drugs that we know will be effective. We finished one trial several years ago. It was a negative trial. We couldn't find anything that was effective. But there will be something that will come along. As of now, we don't have anything that's proven. There is experiments or trials still going on. And the good thing about these trials is that they're risk stratified. They're only taking high-risk patients, because then we know it will work. If you take the low-risk patient and put them in the trial, then you're not going to get any results. So the present-day trials are driven by the risk stratification, and they're using targeted therapies. So they're well tolerated, they're specific to the mutations that we think will help stop the conversion of micro to macro. Because micrometastasis, remember, has already happened. So you're not preventing metastasis, you're preventing the conversion of micrometastasis to macrometastasis. If you learn only one thing from this lecture, this is, I think, the critical part. And this is another review paper, you can read about it. In my mind, if you want to change this curve, and I hope it changes before I die, before I leave this business, would be adjuvant therapy. Nothing else in my mind will change the outcome. And if you say, how am I so sure? Well, next year, if you ask me to come back, I'll show you some new data that we have. It's still not published, so I cannot share it. But that's what it all tells me. The answer is not in early diagnosis or treatment, it's more in this way of thinking of treatment for uveal melanoma. So that's, the time is up. Thank you very much. I hope you learned something or share and gave me the chance to share my thoughts and experience in management and mortality of uveal melanoma. Thank you.
Okay. Thank you, Dr. SINGH. Wonderful presentation. We learned a lot. ¿Alguien del público tiene alguna pregunta o inquietud para el Dr. SINGH? ¿Alguien de todos los que nos ven de los diferentes países de América Latina? Any questions? Dr. ARUN, I have a question for you. When you are doing the biopsy of the tumors, how many samples do you like to take in every tumor? 5, 4, 3? What do you recommend to us in our centers, in our countries?
One sample. In transscleral biopsy, you can take more because it's safe, you're outside. And transvitreal, you're a little more tricky. But I only take one. And for the genetic test or the molecular test, you don't need a large sample. You may not actually see anything. You may see a little brown tinge when you put that in the buffer. That's enough. That's enough. So I don't go multiple passes. That's what you're asking about, how many times you go with the needle. One time.
Okay.
Thank you, Dr. Singh, for that amazing lecture. You put a lot of complex information there and make it, you make it very simple. And I think that's kind of the beauty to making, understanding better how things move along in history. I have a question. So now that we're entering into the prognostication realm, how do you incorporate that into your field? And, how do you deal with situations when you have a large uveal melanoma, but it has low prognostic values on the commercial tests?
So that's a very good question, and there are two answers to it. We know size by itself is important. In comparing the two tests that we have, MLPA and GEP tests, very specifically, MLPA test takes into account the size in the algorithm when it gives you the number of years of survival. The GEP does not do that. GEP is purely based on RNA status. But we know studies, our group and others have done, that indicate that the size is also influencing the GEP interpretation. So first of all, if you were to sample small tumors, only 5% of small tumors by COMS will actually be class 2 on GEP. So 95% are not. Whereas medium and large size tumors is 50-50. So the proportion is affected by size. So that's one thing. And second, if you incorporate the size, the prediction of GEP actually improves. So if you have a large tumor with class 1, I would still think that they have more than 0 risk of metastasis. And we published our study, I think there were like 200 or 300 cases total with the University of Iowa. And we had 3 patients in class 1 that metastasized. That's expected, we know some percentage, but all 3 were enucleated eyes. So we know size is playing a role, although RNA has a bigger contribution, but size is adding a little bit to it. So both have to be kept in mind. So that, I think, again, these numbers are new, let's be honest. And this is something that's in evolution. In few years, we'll have revised numbers. We'll have more variables incorporated in these algorithms, and we'll be more precise. So I tell the patient that this is the sort of guide. This is the version 1.0. And we wait, we'll have version 2.0 and 3.0. We have upgrades as we go along, as we get better data and better numbers. So to say that this is the final answer, no, it's not. And therefore, just say roughly you're on a better side of things, you're on a higher side of things. That's all. Don't pay attention to the number necessarily so much.
Thank you. Dr. Arun, do you think exists any difference between resection, talking about the survival, with endo resection of the tumor? Do you think it's increased risk or lower risk? What do you think about that topic?
Okay. I think here you have to add one more layer of discussion, which is the local recurrence. We know local recurrence is associated with higher risk of metastasis. That is proven. Now, is it because the aggressive tumors are more likely to recur, and therefore they are more likely to have show metastasis, or it is just a function of recurrence? But leave the melanoma aside. Look at lung, look at breast, look at colon, look at any tumor you want. In all tumors, local recurrence means bad news. So uveal melanoma is no different. If you think about it, just forget the site, you look about all the tumors. This is what's happening. In breast cancer, local recurrence, increased risk of MET. So your local treatment, therefore, should be such that the local recurrence rate has to be low. So if you say plaque therapy, local control rate is 95%, recurrence rate approximately 5%, let's say is a gold standard. Enucleation local recurrence is almost zero. So you say 0 to 5% is acceptable. Anything more than that is not acceptable. So if you do endoresection, and I have nothing against it, and your recurrence rate is 30%, that I don't think you're doing any service to the patient.
Thank you, Dr. Singh. We have some questions from the audience, and they've been asking twice. If you do a biopsy on a lesion and it comes out low prognostic risk, why treat it if you think that the genetic transformation happens very early on, and
Right.
you know there's a high risk of visual loss due to radiation? Can you explain that and maybe stratify based on size?
So it's again a very good question. You say, I have a patient, so with high risk, we have no doubt we want to treat it, and that's fine. In a low risk case, remember, local treatment is for local control. Even the low risk tumor can grow and fill the eye, can have extraocular extension, and get into the orbit. When these studies were done initially, MLPA, GEP, monosomy 3, FISH, all of them were enucleated eyes. Half the enucleated eyes is class 1 tumor. So class 1 and class 2 is only, or monosomy 2 and disomy and monosomy 3 are only referring to one aspect of tumor behavior, that is tumor metastasis. Does not stop it from growing inside the eye, does not stop it from causing retinal detachment, neovascular glaucoma, extraocular extension, everything else. So if the patient has a low risk tumor, great, they're not going to die from metastasis, but does not stop them, if you have no treatment, the eye from converting from small to medium to large over time, and then requiring enucleation, maybe endoresection, maybe something else. So I would say the local therapy is for local control. Now, having said that, you say, well, I did the biopsy and the patient has low risk. He's monocular. The tumor is in the periphery. He's old patient. You can observe some tumor as long as you can observe. And they will grow, because growth is not dependent on low risk or high risk. Growth is independent inside the eye. They will still need the treatment if it grows. So you may get few months of it, but not a lot.
Thanks, Dr. Arun. How do you manage the indeterminate lesions? Do you observe or do you treat that kind of lesions?
So we will try our best to make a clinical judgment. We first call it indeterminate lesion based on size. Then I look for orange pigmentation and subretinal fluid. History, I think, is important. if the patient had the examination before, was it noted before, was there a photograph before, is there a growth before, any symptoms with it, any detachment with it, all those things make me think that this could be melanoma, and then I will tell the patient, we call it IML, and we favor it as melanoma. And the other patient has drusen. He just went for a checkup, and somebody happened to dilate him for the first time in his life. And they found something, has some drusen on it. It's incidental finding. No orange pigmentation, no subretinal fluid, no other reason. I say, you know what? It's been found new, I understand it. But the appearance tells me it's been there for a long time. So I'm going to call it IML, favoring nevus, and I'll observe. So just by the risk factors, I don't think you can determine everything. I think history is part that's missing in all of this algorithm. So I can show you nevi that are 3 millimeter thick. I've followed for 20 years, not changed. But if you put the size, it becomes medium-sized melanoma of the COMS. So I think you need to probe very carefully what's the patient's evolution over time. So that's how I manage. I will bifurcate them into first I will call them IML. So patient knows that this is a clinical diagnosis, that there is some uncertainty here. And then we say it's a nevus, we come back, we'll follow. If it grows, I treat you. If the tumor is right next to the fovea, for example, the vision is 20/20, I'm reluctant to jump right in because I know my treatment will make it worse. So somebody told me this long time ago, there's only one thing worse than an aggressive tumor, and that's an aggressive oncologist. It's worth remembering. You may not die from this melanoma, but you'll certainly go blind from it if I treat you. Okay. So I'm not for observation for everything, but you must sit back and see, is it 90-year-old with small lesion that has drusen? Patient has only one eye? I would wait. If it's a 40-year-old lawyer, I'll scratch my head a little bit more. Think harder.
Thank you. Are there patients that prefer not know the results of the gene expression profile, low, high risk, because there is not adjuvant treatment yet? Do you have patients that...
So we patients above 85, I tell them don't get into this business because average lifespan in America is 85, and I say above 85, you already live above average, forget about the testing, you're fine. It's mostly applicable to younger people who are otherwise healthy. They don't have any major comorbidity. They don't have metastatic lung cancer going on and now they have something else coming in the eye. So that also is important. So comorbidity, okay, is important. So yes, we have many, even young patients. They said, and one of them was very smart. He said, well, what happens if I'm high risk? I said, well, we'll do CAT scan every 3 months because it will pick up smaller tumor, MRI every 3 months. And he said, if I'm a low risk, I said, well, I'll do ultrasound every 6 months. He said the difference is only then 3 months, isn't it? I said, yes. I'll only find the tumor 3 months before between one and the other group. And he said, 3 months is not a big deal, 90 days. If I find my tumor 90 days later, what's the big deal? I think he was a very smart man. He understood that the real difference, but it will make a huge difference once we have the adjuvant therapy. So right now we don't have it. We are, I guess, setting up the stage for it. But once we have that, it will make all the sense to do it. And then more patients will want it. You will actually want to then tell them there's good for them to have it if they are in a certain age and they're healthy otherwise. Yeah.
Dr. Singh, I have another question. I think this might be, it's a little tricky, but there's some studies out there that have shown that tumors can be heterogeneous. How do you take that data? It's not a lot. How do you incorporate any of that information into how you explain to patients prognostic tests?
Okay. So that's a very good question. And we know about 15% of sample will show, if you did 2 samples from the same eye, you're going to get 15% discordance. If you did MLPA versus GP, same tumor, analyze it 2 different tests. You're going to get 2 different results. One test may say low risk, one test may say high risk, about 15% of cases. So there's a discordance. We understand that. It's that within the population of cells, there are some cells don't have the mutation. When we do staining for fish, not all cells will have monosomy 3. There are proportional cells that actually are disomy. Sometimes you pick up macrophages, sometimes you pick up RBC cells in the biopsy. So you're mixing many things when you're getting a sample. So there is heterogeneity. But therefore, I tell the patients that this is the rough guide. So when you say 0 to 5% of metastasis, we say class 1 or monosomy 3. Maybe they are not really monosomy 3. We just happen to call it. But let me classify it differently. In monosomy 3 business, when they have it, they have it. The problem is when we say they are disomic and they may be monosomy. It's like false negative. When they have monosomy 3, there's no doubt that they actually have it. When you say they have disomy, then they get metastasis. Similarly, when you say class 2, it's very likely that they are true class 2s. But if you say class 1, maybe they are actually class 2 and then you classify them incorrectly. So when you have a positive test, then you don't have any problem with that. The problem only comes when it's a negative test. That means it's a good prognostic answer. Then you say, is it really true good prognosis or it's a sampling error? And that's why you have certain percentage of patients with good prognosis actually get metastasis.
Doctor, last year I had a case with big melanoma and with metastasis in liver and lungs. That cases, do you perform the enucleation or just to treat with immunotherapy or chemotherapy or whatever, or you don't do the enucleation? What do you do in that cases?
So it's a very interesting question. Again, you guys are asking very tough questions, I have to say. So if you have decided that you will treat the metastasis, then you have to also treat the primary. You cannot ignore the primary and only treat the secondary. It just makes no sense. So whether immune therapy, we know it's only 5% efficiency, right? In UVEAL melanoma. So I would treat the eye, plaque, enucleation, whatever it is. If the patient says, oh, I already have MET, so you do the liver biopsy, you found the MET, for example. And the patient says, no, I'm 90 years old, I don't want to have any treatment. Then you can leave the eye alone, it's okay. So if you're going to treat the MET, then you need to treat the primary. So you need to do the liver biopsy before you jump onto the eye biopsy. Okay. And not the other way around. Not don't enucleate him first and then find out he has MET and then say, I do nothing, you go home and die. Then what do you do, enucleate him? Yeah, that's why you have to pay the attention to the liver first. And you will only do that if you did the imaging before the eye treatment. Many of us are in a rush to treat the eye. They say, oh, you do CAT scan later. No, we do CAT scan before. If I enucleate the eye and then I did the liver scan, then I found a big MET and say, oh, it's too advanced, you can't treat you. Then why did I enucleate it? But you will only avoid it if you did the CAT scan before you did the enucleation.
Thanks. Victor, another question for Dr. ARUN.
Thank you, Dr. Singh. I think that we're kind of running a little bit late on time. So for sake of all the people that have time constraints, I'm gonna let Dr. Morales close the session. But thank you, Dr. Singh. It's been a pleasure.
My privilege.
Thank you, Dr. Singh. Thank you, Melvi and Victor. Thank you. Thank you to all to connecting this time. Thank you. Good afternoon.
Okay. Bye-bye.
Bye.